Hi, I'm Steve Wegner, the Chief Medical Officer for Community Care in North Carolina. We usually refer to it as CCNC, and tell you about a project that was begun with some funding from the Centers for Medicare, Medicaid Innovations that we were awarded last fall. And it's a little bit different from the normal accountable care that you might think of in terms of an ACO. This is more towards moving an organization towards accountable care for a large group of people. So let me tell you a little bit about why we selected a large group of people. And it has to do with the pediatric orientation and the work between primary care and specialists. In the typical ACO, you usually use a community, and that may have a community hospital where most of the patients go to. However, in children, the subspecialists are located at academic medical centers. And usually the patients don't just go to UNC or Duke or ECU, they end up going to different specialists at different hospitals. So really, to make this effective, to make an accountable care organization movement, we had to include the whole state. And as you know, CCNC works primarily on Medicaid population and has done a very good job of working with the primary care doctors. This initiative takes us to the academic medical centers and also 7 tertiary hospitals that do subspecialty care. Let me tell you about a patient that we came across early on in the project. And this was a 12-year-old who was a victim of a hit and run. And they had multiple problems with multiple organ systems involved, skin problems, respiratory problems, had to have a trach, and had, at the end of this hospitalization, had multiple specialists involved. They went back to their community and got some care, but there was no coordination between the primary care and all these specialists. And so that's where we used our care coordinators to make that connection better. And as a result of this case, we've learned that these special patients, and we refer to them about 5% of the population in Medicaid, take up over 50% of the resources. And typically they will end up in the emergency room of the academic medical institution because sometimes that's the only way they can reach the specialists. So we want to make a better communication system between our primary care docs and the specialists, and the specialists want to do this also. In fact, for this project, we got all of the academic medical centers to agree to participate, as well as the 7 tertiary hospitals that also take care of these patients. And we have developed co-management plans where the specialists and the generalists talk to each other about how they can make agreements as to common referrals and then even these difficult patients. As an example, pediatric GI is filled, their schedules are always filled, and it's very difficult to get a patient into them. And if you ask them why, they say that almost half of the cases that they have involve either constipation or reflux. And that's really a very common condition that all primary care physicians know how to handle. So we got all of the doctors together. They came up with a set of guidelines, and they can use these guidelines not just for the doctors as to when to refer and when not to refer, but also we can give this to the patients and say, all of this, the specialists in the state of North Carolina agree that this is the way we need to treat these patients. So now you can call up and get an appointment for a really sick patient who may have inflammatory bowel disease instead of their schedules being complicated with these ordinary problems. But we can also work in co-management on very difficult patients like the boy that I told you about, so that the primary care physician knows what he can do and when he needs to call a specialist. And we even have a special system where we can secure message between those two and ask questions about drugs or any other problems that may come up. As you might have guessed, getting all these people together is not an easy task. I think that clearly the subspecialists and the primary people were motivated to do the right thing. But I think community care was able to provide the organizational structure, because we had long-standing relationships with these hospitals and these physicians, to put something like this together, so that our care managers can go into the academic medical institutions. They can show them a doctor's care plan that is a summary document of exactly what that primary care doctor needs to know. They can sign off, make adjustments, and then we can make sure that document gets back to the primary care. So none of these tasks are easy, but if we're going to move towards accountable care, to be responsible for these patients, this is what we have to do. We have to work together, and I believe that co-management agreements are going to be a very useful tool in adult care as well.